Megan Haggard. I'm a program manager here at Corp. There will probably be more people joining us, but we do want to respect your time and make sure that we leave plenty of time to answer questions from those in attendance. So this is just a brief overview of our agenda. Malia Christensen, our Executive Director, will be giving an introduction. Then Meredith Roberts-Tomasky, a Program Director here at Corp, will go over some more background and the actual measures. Then Doug Ruff, our Senior Analyst, will go more in-depth into the methodology and the reports themselves. And we have a special guest today, Lisa Krantz, the Administrator from Family Medical Group Northeast, who has been very involved in this work with us, who will also be giving us some insight, as well as leaving plenty of time for questions and answers at the end.
Great. Very good. Thank you, Megan, and this is Malia. Welcome to all of you. We're thrilled that you could be with us, especially given the lovely weather, assuming the majority of you are in Oregon and could have spent some time in the sun, that you're instead spending it with us to talk about the exciting rollout of the total cost of care information. For those of you who might be new, we're going to just go through very quickly background on Corp. Many of you may be familiar with our mission, which is to improve the quality and affordability of health care in Oregon. We started in 2000. We're a nonprofit organization. We believe that our special place is as a neutral, independent organization that represents all stakeholders, including health plans, consumers, purchasers, policymakers, physicians, professional groups, hospitals, and health systems and health plans. We have over 200 volunteers who serve on over 11 standing committees. We have three major key strategies. We lead community collaborations. We provide unbiased quality and utilization information, which we've been doing since 2007. And today we're excited to share with you yet another series of metrics that will add to that in terms of cost. And we also provide data and analytics with the data that we have. We are a participant in a number of national initiatives, including we are part of the Aligning Forces for Quality project of the Robert Wood Johnson Foundation, their largest singular effort nationwide. We're one of 16 communities. We've also been recognized by as a chartered value exchange by the Agency for Healthcare Research and Quality. And we're a member of the Network for Regional Healthcare Improvement, 30 organizations like Quality Corp that are across the country. And we are a CMS qualified entity and one of the first three recognized in the country and publicly reporting on quality data for Medicare population. Just to give you a sense of what's in our database, we've been reporting, as I mentioned, since 2006. We have over 3 million unique patients in our claims data. We have unique providers, over 700,000 across Oregon, and we have a provider directory that actually can attribute patients to providers by physical address across Oregon. On the next slide, when you look at what that means in terms of the breadth and the comprehensiveness of the data, we have over 80% of the fully insured commercial population, over 35% of the self-insured, 100% of Medicaid, and 92% of Medicare now that we're a qualified entity. We have been reporting on metrics that are for both the adult and pediatric population for years. We started with a very traditional HEDIS set of measures. We expanded to utilization, and today we're really thrilled to be able to talk to you about the addition of cost measures. We use that information in our statewide annual report, which is a high-level snapshot of how we're doing at the state. On the next slide, you can see an example of a thumbnail of how we're doing compared to both Oregon benchmarks and national benchmarks. And on the next slide, you can see how we produce that information for consumers in a translated variation that actually allows citizens of Oregon to see how providers are doing in a number of different quality metrics. Before I turn it over to Meredith, I'd just like to say that today is really significant for a number of reasons. We started this journey over 2.5 years ago, where the Board of Directors for Quality Corp decided that if our organization was really going to support the triple aim, we had quality measures, we had information around patient experience and population experience, but what was clearly missing was information about the total cost of care. And so the reason that the board and staff have been so committed to this work is because we believe that providers very much need this information in order to be able to achieve the triple aim. We believe eventually purchasers, consumers, health plans, hospitals, and the citizens of Oregon will find pieces of this information useful in their various lenses of healthcare, and we're very excited to be working with partners across the state on this effort. And with that, I will turn it over to Meredith so she can do the next level of detail about the project.
So really quickly before Meredith begins, I will just let everybody know that you can use the questions feature on your toolbar on the side to submit questions, and we will read those out at the end as we answer them because all participants are on mute. So if you do have a question during the presentation, feel free to submit it, and then we will answer all questions at the end. Meredith?
Yep, thanks Megan, and thanks Mylea for the introduction. I am thrilled to be able to talk to you today about what we've been up to for the past 2 years. And as Mylea mentioned, this has really been an effort that has gone over a long time and has involved a lot of people. So we're finally able to share something with the community at large. So we're excited to be able to do that today. So if we can get to the next slide, Megan. As Mylea mentioned, we are an Aligning Forces for Quality grantee through the Robert Wood Johnson Foundation. And through the 4.0 grant, the fourth round of funding, we really decided to focus our efforts on figuring out what the total cost of care means for Oregon. We also got an opportunity to work with the Network for Regional Healthcare Improvement on a project also funded by the Robert Wood Johnson Foundation that took a look at 5 regions across the country. So the regions were Minnesota, St. Louis, Oregon, Colorado, and Maine. And the goals of the study were really to explore the standardized measurements to provide trusted information and to enable comparisons across the regions. So to do this, we've been working with physician partners over the past year or so to develop strategies that really the people on the front lines can use to reduce costs. We started this effort at the National Physician Leadership Seminar back last August. We invited 4 Oregon physicians to attend the seminar along with physicians from the 5 regions to really understand these measures and to share ideas about what we should do with them. We also, as one of our goals, wanted to develop clinic-level reports for primary care practices, which is really the majority of what we're going to be talking about today. So this spring, clinics with at least 600 attributed patients will receive or have received reports, and this accounts for over 150 practices. So I'm going to go briefly into what the measures are that we're using, and then Doug is going to go into a little bit more detail. So the measures are total population level measures that look at per capita costs for a clinic's attributed panel of patients. And the important thing to remember about this is it includes all the care delivered to the attributed patient. So professional, outpatient, inpatient, and pharmacy costs are all included. This also includes all payments made by the insurer and the patient itself. And we do get both of those pieces of data in our database. It's important to also note that we are risk adjusting to account for each clinic's unique set of patients. So we're using a risk adjuster called the Johns Hopkins Adjusted Clinical Groups ACG risk adjuster. And this risk adjuster basically looks at age, gender, and illness burden of a population. And it's a method of estimating a population's illness burden. So it helps level the playing field between populations by accounting for some of the variation inherent in the fact that clinics see different types of patients. The measures are based on a methodology developed by Health Partners, which is an integrated healthcare system based in Minnesota. They've been using these measures for over 10 years, and in the past few years, they've seen more and more adoption around the country. So currently, there are over 90 licenses for this measure in 29 states. So it's really gaining traction around the nation. So one of the reasons we chose to go with these measures are they are NQF endorsed. So back in January 2012, the NQF endorsed two measures, Total Cost Index and Resource Use Index. And this endorsement was actually the first of its kind as a population-based cost measure. Of course, the NQF goes through a robust review process, so we can be sure that the measures are reliable and valid. So just to go a little bit more into what total cost and resource use and price means, the total cost index includes medical and pharmacy costs, and it accounts for both price and utilization. So it covers all attributed patients and it accounts for all the costs in medical and pharmacy over a one-year period. Resource use index is the utilization component of the total cost index. So it measures the frequency and intensity of services, and it uses standardized pricing to kind of isolate the resource use from the total cost. The price is actually just a simple calculation. You remove the resource use from the total cost index component. And it really tells us what the actual price of the service provided was. So it takes into account contracted rates and arrangements made between payers and providers. So really the point of these measures is to highlight cost savings opportunities and also potentially identify overuse and inefficiency in delivery of some of these services. So with that, I'm going to hand it over to Doug, who is certainly more of an expert on these measures and the methodology than I am. And he'll talk about the methodology that we used.
Thanks, Meredith. In a couple minutes, we will be reviewing the clinic-level report package, the package that includes quality, cost, and utilization that we've been sending out over the last couple of weeks that Meredith mentioned. But first, I'd like to go into a little more depth on how these two cost measures are calculated. As Meredith said, we're using the two health partners total cost of care measures to compare clinics to an Oregon average. And that's based on, the average is calculated based on clinics that are receiving these reports. The first measure, the total cost index, takes into account all services provided and compares it to this average for all clinics. So first we need to calculate the total PMPM, or the total per member per month medical costs. And these are all costs paid by the patient and the insurance company. And they're divided by the number of months that those patients were insured during the year. A similar calculation is done for pharmacy because pharmacy member months can be different. And then those two are added to give us the total PMPM. And this is the average per member per month cost at the clinic. In the clinic comparison reports, we're calling this the raw PMPM because it's the per member per month cost before adjusting for differences among the clinic patient population. The total PMPM is then divided by the risk adjuster, as Meredith mentioned, the Johns Hopkins ACG, to calculate the risk-adjusted PMPM. And this PMPM is higher or lower based on the diagnoses, age, and gender of the patients at the clinic. Finally, the TCI, or total cost index, can be calculated by dividing that risk-adjusted PMPM by a peer group adjusted PMPM, which is the Oregon average that we were discussing. So clinics with a TCI score above 1.0 have higher total costs than the average clinic. Conversely, clinics with a lower score have lower costs than the average. The second cost measure is the resource use index. Instead of using the cost paid by the patient and the insurance company, this measure, as Meredith said, uses a standard cost for each service. This way, if two different patients receive exactly the same services during the year, they would have exactly the same resource use. It doesn't matter how much the insurance company paid or the patient paid. So this measure shows the intensity and volume of services the patient receives, irrespective of the price. and it can indicate if more services than necessary are being provided. So we mentioned standard weights. The standard weights that are used to calculate the resource use index are called the total cost relative resource values. The resource use index has a very similar calculation to the TCI, but instead of using the actual cost, the TCRRUBs are used. So that's basics of the two measures that we're looking at. I can go over a bit of the report package now. So I believe some of you have received this report package and will be or others of you will be receiving them. And they've gone out both by email and by mail to 69 different medical groups. 123 adult reports and 44 pediatric reports were sent. And just so you know, the reports were sent to the attention of the administrator of the online portal, the provider portal that Corp has. The report package consists of a 2-page cover letter, and then a 2-page definitions and glossary sheet, and then the 8-page report. And the report is broken out by an overview, and then goes into inpatient, outpatient, professional, and pharmacy services, with other parts breaking out imaging, ER, and chronic condition. And finally, there's an FAQ in the package, which includes a section on how these reports can be used. We've heard from clinics that that's helpful for them to look at different ways they can look at the reports and maybe make them actionable. So for the clinic comparison reports, there are separate adult and pediatric reports. There's a requirement of at least 600 attributed commercial patients and legal agreements between the medical group and Corp. The measures are limited to patients between ages of 1 and 64 inclusively, because populations below or of babies and folks over 64 have pretty different cost profiles. And so we're limiting to 1 to 64. The measure limits 1 to 64 to keep the populations pretty more uniform. Finally, the costs are capped at $100,000 per patient, also to keep the populations similar enough to compare. In Oregon, Corp is calculating these measures for about 35% of the commercial population. We've got 5 of our data suppliers that we're able to use cost data. We do have several data suppliers that at this time we're able to use the cost data. And the analysis represents over 470,000 covered lives. So in the package, there is a reference to our website as well as an email address, costofcare@qcorp.org. Please send questions to us if you have any after we finish up with the webinar today. So on the next page, we've included a couple slides that show examples of the kind of information that's in the report. On this slide, the chart in the upper left shows the data from the raw PMPM, the adjusted PMPM that we discussed, the Oregon benchmark PMPM, and then the last 3 columns are the 3 measures that we were talking about, the total cost index, the resource use index, and then from that we can derive the price index. And in this case, this sample clinic has a price index for professional services of 1.11. That indicates that the prices that are being paid for professional services at this clinic are a little higher, about 10%, 11% higher than the state average. A scatter plot down at the bottom shows where this clinic lies in relation to other clinics on resource use and price index. we have a drill down that shows the lower level service categories that we're showing in the report. In this case, inpatient facility. There's a more detailed grid showing the costs and the indices, and then also a scatter plot for each of the 4 service categories. So now we're fortunate to have Lisa Krantz, who's the administrator at Family Medical Group Northeast, and she will speak about her experiences with the reports at her clinic.
Thank you, Doug. Can you all hear me?
Yes, you sound
okay, great. Thank you. Well, last year, while they were working on the cost of care initiative, Corp convened a multi-stakeholder group known as the Cost of Care Committee. And the group consisted of physicians, clinics, and health plan representatives and some other advisors. The committee's purpose was to meet with the Corp team on a monthly basis and provide insights and feedback about the reporting formats and the potential uses. And I was really impressed at most of the meetings. The main question that was brought up was by the Corp staff was, how can we make these reports meaningful and useful to the physicians so that they pick the report up, they use them, they understand them, and that they can make some actionable steps based on those reports. I had the privilege of being on that committee since last summer and was very impressed with the process, even at looking at the coloring of the graphs so that information would pop out. In February, our clinic physicians here at Family Medical Group were part of a focus group where the first trial of these reports were rolled out. And I was really surprised by the physicians. Generally, when they get reports from health plans and things, they review them and then kind of toss them aside. The interesting thing about these reports was because they started out explaining a little bit about our clinic, it really hooked the physicians into getting involved in the report. The interesting pieces that we found were it just started a lot of discussion around the physician group. And then the focus group ended and folks went away, and then later that afternoon in the hallway, physicians were coming to me with reports, and they said that they had talked to their other physicians down the hallway and saw some things that they wanted more information about. They wanted to know if I could drill down and find out how much we were spending on certain parts of our medications that we were delivering in the clinic. And I have to say, as an administrator, it really surprised me. They were starting to get engaged in the information. They were looking at opportunities, and they were asking, how are we different from our peer group, and what do we do differently? What can we do better? Where are our opportunities for improvement? These were all really, really good discussions. And I guess the thing that's kind of carried forward on that is the engagement of the physicians to want to know more information. And it was the first time our group had ever had cost of care numbers provided to us that was grouped together from multiple health plans. So they're very excited, and I just want to say to the Corp staff, they've done a really great job in putting out this first set of reports to make it useful and meaningful to us. And I know they'll be updating things as we go forward, but they've done a really great job, and I'm very pleased as part of that process. Now I'm going to turn that back to Doug.
Thank you, Lisa. As we talk to clinics, we at Corp are finding that these reports can validate things they already think about their practice and help them dig in, look for things to dig into further, and we're hoping that you will have similar experiences to what we've seen other clinics have. So as Mylea mentioned, each year Corp releases our statewide report on healthcare in Oregon. This year, in addition to looking at quality, we plan to look at some of the cost that we're finding with these two measures. We've started to take some preliminary looks at this. One of them is on your screen now. This chart shows the variation of different clinics on the total cost index. So we've got some that are quite a bit below average and some that are quite a bit above average in the state. We'd like to look at things like this and then other characteristics of clinics to try and see what's driving variation in the total costs. Additionally, we want to compare quality and cost. Our preliminary looks indicate that cost index is not very well coordinated with our quality metrics, as this shows here with the breast cancer screening versus the total cost index. The scatter plot is kind of all over the place, which means there is very little correlation between the two. So more to come on that. I'd like to return to Meredith now, who will review the activities that led us to where we are and where we're going from here. And again, if any of you have questions, we will have time for questions after the webinar, but you please contact us either by email if you have further questions. Meredith?
Meredith, are you on mute? You might have lost Meredith. So we'll keep rolling with the cost of care rollout activities. So as has been previously mentioned, we began with the National Physician Leadership Seminar that was at Stanford. We have also had, as Lisa mentioned, the privilege of having the Cost of Care Steering Committee that has been meeting regularly throughout the last year. The Board of Directors for Quality Corps has also had 3 presentations, and the Measurement Reporting Committee that is a group that is made up of over 20 different representatives, again, from all stakeholders, including health plans, hospitals, consumers, and others, have also weighed in throughout the year on the technical pieces as well as the translation pieces. We've been working hard on the outreach to make sure that people were aware of this activity. We've been touching base and doing presentations to clinical groups, to independent practice associations, to other physician leadership organizations in the state and other professional organizations, and would welcome your suggestions for other opportunities throughout the year. And then, as Lisa mentioned, we also did the focused interviews. We had, through our Robert Wood Johnson funding, a nationally recognized firm, AIR, actually conduct those focus groups so that we could make sure and really get the rich combined feedback from the providers that participated in those settings. We're doing the webinars here today and also another in May, and are also planning our activities for summer and fall. And the next steps, we are delighted because last week we actually got the news that we've received a second round of funding through the Network for Regional Health Improvement Collaboratives. Nationally, we'll be participating with the original 4 regions that Meredith mentioned, as well as some new organizations that will be joining, who will basically be learning from the experience of the first 5 communities. One other thing that we're very excited about, in most of our focus groups and conversations with providers, we heard, it's very nice that you're doing commercial, but would you also quickly do Medicare and Medicaid information, because from a practitioner's perspective, really what docs are interested in seeing is kind of a combined view of practice. So this measure hasn't been endorsed for those uses, but we're interested in working with our national partners to see what we can do in these areas. And then, as I mentioned, mentoring other communities. We're really interested in now that we've sort of got this baseline year working now over year trend variations. And I think the most critical work that lies in front of us is what to do with this information. So we were committed this first year into getting the measure implemented well. And all the information that's been presented to you has been about releasing this information privately to providers in the first 2 rounds so that we could test the methodology and make sure that it was working. But the expectation is that the advisory committee and others will help us explore how might this information now be useful to other groups, and how might the cost of care actually be used to create new materials and products for others who would also find it useful. And I think with that, we would be most interested in your questions. And as Megan said, you can type questions in. Do you have some in queue, Megan, or shall I open it up to any bold folks out there that would actually like to verbally ask a question? Or you can't?
No, well, I'm muted, so just please submit questions through either the chat feature or the question feature on your pane on the side. We do not have any questions right now, so we will wait a couple of minutes and see if any come in. But as Mylea mentioned, please feel free to ask us questions. We are very happy to answer them and talk with anybody who is interested in this work that we've been spending so very much time on in the last year and a half.
I think one question that I know might be on top of mind about the next steps as far as reporting. So typically for Q-Core in our quality measures, we usually will report a quality measure twice in a given calendar or 12-month period. Again, if it's a new measure, to test that it's working as intended and that it's appropriate for public reporting. In this case, this measure is not being publicly reported for these two measures, or for these two first parts of the cycle. So you might be curious about that. We just want to make sure that we clarified that.
And we did have a question come in. Since the risk score adjusts for differences in age, why do you exclude members greater than 64 from the analysis? And the risk adjuster does, but at the ends of the age and at the edges of cost and high utilizers, the risk adjusters don't do quite as good a job. In fact, both at the PED end and at the senior end of ages, they don't do quite as good a job. So it's just a way to make sure that the overall panels are closer together. There's one on public reporting.
So we did just get another question about how are you anticipating to publicly report? Will it be similar to the current quality system?
That's a great question, and I think we're very focused right now, again, on the methodology and working directly with the provider groups who have received the information to work on the measure. And part of our work over the next year will be at what level and what part. So Doug mentioned, for example, the statewide report. We're planning on doing a statewide kind of snapshot, like the variation slide that Doug showed about, you know, what are some of the early things that we're seeing in terms of variation? What are some of the interesting findings about some of the specific categories within this report? But for this year, during 2015, we would not expect that we would be doing translation and public reporting. And in fact, I think some of what the Cost of Care Advisory Committee is going to talk about is what, if any, of this information is produce something that could be useful to consumers in terms of their choices and thought process. And we've heard from other stakeholders like purchasers or policymakers or health plans or IPAs and others who think that there would be interesting translations of the information. But at this point, we have not made a decision about how or when or if we will translate to a consumer level in the next short term. I'd say 12 months?
Yeah, no, likely. We have another question. Which insurers are allowing you to use the data for the cost of care? And we do have 5 carriers that have given us approval to use their cost at this time. It's MODA, Pacific Source, Providence, Regents, and Trillium.
And this is Mylea. I would just add, we currently have 17 data suppliers who give us the data. The reason why a number of them have given us permission, but the population's not right. So for example, if it's a Medicaid managed care plan, we don't have a Medicaid measure. We have Medicare, but this isn't a Medicare measure, so those individual plans were excluded as well. And Doug, the percentage of the commercial population that this represents in your previous slide is?
About 35% that we're able to run cost on. Your quality scores report on clinics with at least 30 patients. Why do you require 600 plus patients for cost of care reports? The cost overall is just a little more volatile, and Health Partners came up with the 600 number that they took to the NQF for endorsement. So that's why we are using the 600. It's NQF endorsed. We are looking at being able to lower that, but just with the way the risk adjusters work on this and the way costs vary, we will never get down to a patient level of 30. It's possible we'll go down to several hundred and below the 600 threshold, but just with the way the measures work, it does require a large enough population to be attributed. Any other questions? Oh, excuse me, I misspoke on the carriers. The last carrier is Tuality. Any other questions?
All right. If not, then I think we will conclude today's webinar. We do have another webinar coming up.
We have another webinar scheduled for the 7th of May at 8 o'clock in the morning. If any of your colleagues would be interested in attending, the registration links can be found on our website, on the QCore site here, and we would be happy to have. And feel free to pass along the information. We are also planning to in-person events. That information is also on the website. So if you have other questions that come up, as Deb mentioned, you can feel free to email us directly at the email address listed on this slide, which is costofcare@q-corp.org. And we will be monitoring that inbox and answer any questions that you do have that come in. And we thank you all for joining us today, and have a great day.